you may have been a little confused by the terminology, but anti-infective is a general term, right? So anti-infective, does that also cover antifungal and antiviral? It actually does, okay, because those are infections. So it is a general term, but it really is the more proper term for what we call antibiotics, because antibiotics have their own specific way of being made actually from bacteria, but we generally call things that fight substances, drugs which fight infection, antibiotics. We give them a general term, and that's okay, as long as you don't mix up what they are and what they do. But they were subdivided in your book into the anti-infective agents which address bacteria, which is what we're talking about today, and those which fight fungi and viruses as well. So in discussing these anti-infective agents, we're going to talk about dental infections. This chapter, as you can see, was very much more directed towards what we do in everyday practice, okay? Very much directed towards dentistry. And indeed, dentists do write up to 10% of all antibiotic prescriptions, which is pretty large considering how many other medical infections that there are. So we're going to talk a little bit about the history of anti-infectives or antibiotics. There's a lot of definitions in this chapter. I really want you to get those down. I have them in the slides to help you go over them, but really getting those down would be a good idea. I don't often tell you memorize, but I actually would memorize those definitions because it's going to get in your way if you don't understand the differences between them. We're going to talk about culturing and sensitivity of the types of bacteria that we want to attack, because that will help us to be much more specific in the way that we treat them. Because by not doing that and just throwing antibiotics at people, as you know, you hear about these massive outbreaks of staph infections and MRSA and all of these things. It's because the bacteria are becoming resistant to the antibiotics. It's like if you hit it to kill it, it just gets stronger. Like what doesn't kill you makes you stronger. That kind of happens with the bacteria, okay? And it's getting stronger and it's becoming resistant to what we're throwing at it. What are the true indications for using an antimicrobial, anti-infective, antibiotic, kind of all similar? And what are some general adverse reactions and disadvantages associated with those things? Because there's the good, the bad, and the ugly, if you will, in between there. So what we know about infection in dentistry is that we talked about pain alleviation with our analgesics a couple of weeks ago, and that seems to be probably the number one thing that gets people to go see the doctor or dentist, right? When you're in pain, you want to address it because pain tells us something's wrong. Secondary to that, the thing we tend to medicate the most is infection, especially in the dental office. That's the other thing that gets people there. And sometimes the pain associated with the infection, or the swelling associated with the infection, or the feeling of fever and malaise and all of those things that come along with an infection that does not seem to go away. We do divide these different types of infections into several types, bless you, and depending on the type and what they are and what causes them, we may or may not use antibiotics to treat them. So, of course, our first one and the most common infection in the world is caries, okay, or the disease that causes cavities. Okay. Then we have periodontal disease. So these are our meat and potatoes, right? This is why we're going to be in business doing what we do. Then there are the localized dental infections, one of which you can see on the screen there. And I'm kind of in the way here. There we go. I don't know who moved the room around. Okay, a localized dental infection, or something we often know of as an abscess. And then a systemic infection, something that actually gets into our system. And dental infections, if they are not treated, can become systemic and indeed attacking the rest of our being. We know that there's an evolution or a process when someone develops a dental infection, taking it from its beginning stages, and if it's not treated, into a later stage. And you know the difference between something being aerobic and anaerobic, right? Yeah. Aerobic meaning it's working with air, oxygen, okay? And anaerobic, we think of it going deeper, right? Okay, and it's working in the dark, in the caves. And the bugs that are in the caves there, you know, are able to kind of grow without the light, you know. I think of them as being kind of nasty, and they are. And they're able to grow unabated and cause a deeper and a more serious infection. So when we start with an infection. It's often something that's aerobic bacteria, gram-positive cocci. Do you guys remember doing experiments in the lab, you know, and staining for different types of bacteria and all that? Yeah, you didn't like that?
I love it.
You love it. Oh, okay. She loves it. All right, that's good. You might really like to go into perio and be pulling bugs out of people's pockets and sticking them under a microscope.
Yeah.
Some offices do that. They sure do. Wait till you have perio and talk to Miss Fasichesia. Okay. And in you know, because in moving along, if that infection isn't then taken care of, again, it moves deeper into the tissue, and the different types of bacteria start to proliferate, and it becomes mixed with some of the gram-positive and gram-negative anaerobes. Okay, those that grow in the deep in the dark. Okay, and then we go deeper into there, and we've got a mostly anaerobic infection. And at different stages, we may be treating it with different antibiotics if they are indicated. Okay. And by the time you get, with a dental infection, by the time you get to like way down there and fucking anaerobic, you might start to see, that's when you might start to see those periapical changes where you see how there's a little darkness there. You can probably see the darkness better on the side screens there, because we've had an infection within the tooth that has not abated. Do you think something that's deep in the bone there is going to be aerobic or anaerobic? Anaerobic. And it is now started throwing off all kinds of you know, other byproducts, and the infection actually displaces bone. Okay, really interesting. And if that's not treated, it can get worse, and then sometimes will funnel its way out to the outside and start to cause something that looks like that. Okay, and sometimes not. So it just depends. Okay, so in dentistry, and this exact thing is not in your book. In medicine, rather. Looking statistically, they crunch numbers on prescriptions that are written and why they're written, and lots of times they do these from different emergency rooms and whatnot. And in general, antibiotic prescriptions for medicine, particularly things like penicillin, are down. Okay, the practitioners are less apt to immediately throw an antibiotic at someone who has some sort of infection that we don't really know exactly what it is, but they're less likely to treat with an antibiotic. Prescriptions in dentistry are still on the rise. And we have some theories about why that's true. And it could possibly be due to postponement of care. And if someone who does not have access to care, does not have a dental home, shows up in an emergency room, what do you think they do? They give them a pain med and they give them an antibiotic, because they don't do dentistry in most hospitals. Okay, but we don't have an access to care issue, right? Yeah, right, we do. Okay, so that's one theory, and that's proven to be true in some cases. There's also patient expectations. You go with pain or infection, and you expect to get a prescription, yes? Okay, so we have to do a little number on ourselves in education, and then educating our patients about maybe not expecting that, but actually treating the cause. And when the cause is not treated, we give a pain med and an antibiotic. Okay, that's what we do. Antibiotics save lives at the right time, but they're also overused. And it's not based on the evidence, okay? The evidence, I hate when I make typos when I see this. It's not based on evidence, it's based on we don't know what else to do, so we'll throw a pain med and an antibiotic against it. If you look at the evidence for how infection should be treated, okay, including pre-medication, all right, which was not based on evidence either, then you wouldn't have prescribed an antibiotic quite as often. So educating ourselves and educating our patients is a must. And what they're calling this now, and I'm talking about organizations like the American Dental Association, is antibiotic stewardship, okay? Stewardship means taking care of something, okay? You take it and you're a steward of it, okay? You're going to take care of it. And taking care of this idea of, being very discriminate when prescribing antibiotics. So there is awareness that there's a problem, and I read a number of articles and actually went on a webinar about antibiotic stewardship, and this is something that dentists are being made aware of and asked to really exert caution when prescribing antibiotics. Having said that, we're also going to talk about how well they work, because they really are a miracle. Okay, so in dental oral infections, we'll start with caries, okay, which is the most common infection that we know. And we know that it's produced by Streptococcus utans infections, right? And that the best medicine for caries is, number one, preventing it to begin with, right? Oral hygiene, sealing it, okay? Or if we've gotten to the point where we've already had tooth tissue destroyed and it's cavitated, we're then going to restore it by surgically removing the infection lesion, right? It's surgical. We actually remove body tissue, tooth surface, and we restore it and get rid of the infection. Rarely do you hear about antibiotics in caries, probably almost never. There are some protocols. Have you guys heard of CAMRA yet? Did I mention that already? It's a caries risk management program where if you have someone with rampant decay or a child that seems to develop it very early, or people that are just very cavity prone, if you will, because of the flora in their mouth, they might actually culture them. They might actually do a short course of antibiotics, or more likely an antimicrobial rinse like chlorhexidine, okay, may be used, but that's very rare. You don't treat a Streptococcus mutans infection with an antibiotic. You don't treat caries with an antibiotic, okay? High risk assessment may, on the rare case, prove that to be helpful, but that is not the norm. It's not something that should be expected. Now, when it comes to periodontal disease, which is a disease we treat, don't we? Okay. Dental hygienists are most responsible for periodontal debridement and treating patients for an infection. And when you tell a patient that you're treating them for an infection, they're like, I have an infection, don't I need an antibiotic? It's probably one of the first things that they say. It's like, no, you don't. But we do need to address this, and we address it locally. Debridement that you do is first-line therapy for periodontal infections, okay? For periodontal infections, starting from gingivitis all the way through, you know, type 4 periodontal disease. If it's unsuccessful, or if after repeated periodontal debridement, you know, you've heard of scaling and root planing, we call it periodontal debridement. It is the same thing, but out in practice, debridement tends to not mean scaling and root planing. The insurance codes still call it scaling and root planing. If that is unsuccessful after repeated attempts, we may use an antibiotic either locally or systemically. And often that should be based on the specific type of bacteria that are there by culturing them. That is the best way to approach that. It's not always the way it's done. And we know that with experience that a dentist and hygienist that are treating patients for these problems day in and day out, most often in a periodontal office or in a good general office where they do a lot of periodontal treatment, they're going to know which antibiotics to use, or they're going to identify for those resistant people, they're going to identify through culture what it is that's needed. But we don't throw an antibiotic at this, we debride it, first and foremost. Now what about those localized dental infections that have kind of gone to the next step, okay? So you have a perio or an endo abscess, perio meaning within the periodontium, endodontic meaning within the nerve of the tooth, like we saw with that periapical abscess. We should still treat these locally. The abscess should be drained. So you establish adequate drainage first, okay? Antibiotics are going to be reserved for those people who are immunocompromised and can't really fight infection. But for the average person who is called immunocompetent, okay, who can fight infection, we're going to use localized measures. We're going to drain it, we're going to treat it, we're going to do the scaling and root planing, we're going to do everything we need to do, and only treat severe, recurrent, resistant infections, and most often that would be in someone who is immunocompromised. Okay. Do you remember some of the conditions for which people would be immunocompromised? AIDS, HIV, what else? Who has trouble treating an infection?
Joint replacement.
Infection? Patient with diabetes. You guys talked about that in clinic lecture. 2 weeks, I think, we'll have our lecture on diabetes medications. Really, really important. I'm also going to introduce you today to a project that we'll have, a polypharmacy assignment. You probably saw that in your what is that called? Your syllabus. Okay, you saw that in your syllabus. Can't think of the word. So I'll tell you about that, and that's going to involve coming up with a case study for a patient with diabetes or a patient with cardiovascular disease. You guys having fun? Am I too funny? I keep you awake. Okay. I go on last for board review, and like everybody at the end of that is like all hyper again because they've been like falling asleep for 2 days. So I keep them awake. And if I have to do it in the course of it, I make an idiot of myself. I really don't care. It doesn't matter. Okay. So remember, those that are immunocompromised are going to possibly need a little more help, and that does include patients with diabetes. What about systemic dental infections? So we're talking about an infection that has not abated. Maybe the person never went for treatment for whatever reason that might be there. They're of dental origin, but they're now producing fever, malaise, tachycardia, okay, when someone has a systemic infection. If antibiotics can be used if the infection cannot be drained or if it is persistent, and it may be critical at this point. I used to have a slide in here, I guess I took it out. There was a story a few years back, and it was one of the flags that we hold up for, you know, that the fact that we do have an access to care problem in this country when it comes to dentistry. And there have been deaths associated with systemic dental infections. And there was a young man who was 13 years old, I believe he was from Virginia, Diamante Driver was his name, and he literally died of a dental infection. That's criminal. That's absolutely criminal. And he had, his mother had tried to get him into care, and it was just a really horrible, sad story. So there are times when an antibiotic is needed, but we hopefully don't get to that point. Yes, Jess?
There was one not that long ago where a man died.
Yeah.
I think he was a truck driver or something.
I think it was only months ago, I
Yeah.
think. Yeah.
Yeah.
I mean, they've been traced to things like brain infections and what. So we're talking about disease that has been there for a long time. These things don't happen in a week or two. Okay, we're talking about going months or years without treating a repeated infection of our teeth. Yes.
Any pain and they don't realize it's there.
Sometimes these kinds of problems can get to are you amazed you're going to see some periodontally involved patients who are not even aware of what's going on in their mouth? For some reason, we've come to accept discomfort and pain in our mouth as part of life, and some of it happens without people being aware of it. Why aren't they aware? Because they haven't, no one's looked in their mouth in a very long time. You know, that's not something that really should be happening, but it does, unfortunately. So we're trying to deal with it.